Good morning. Thank you so much for joining us today for our distinguished speaker series. We have Dr. Ezra Cohen joining us today, and he'll be discussing a very interesting topic, how to use precision immunotherapy to treat cancer. So we're happy to have him here today for our distinguished speaker series. Before I tell you a little bit more about him, I'm going to introduce myself. My name is Nancy Walters. I am the Executive Director of the La Jolla Community Center. And if you're new to the center and to our programming, welcome. I hope that you join us for other classes that we have going on or other special series. Please visit our website. It's ljcommunitycenter.org to learn more. We are a nonprofit organization and we host a lot of programming throughout the week that serve adults and seniors, but everybody is welcome to our programming. We host everything from art classes, we have meditation, we have yoga classes, we have special events and speaker series. So we hope to see you back here soon. A little bit of housekeeping before I tell you a little about Dr. Ezra Cohen. If you have any questions during the presentation, please feel free to use the Q&A function at the bottom of your screen. You can also use the chat function as well, and we'll get to those questions at the end of the presentation for about 10 or 15 minutes. So let me tell you a little bit about Dr. Ezra Cohen. We're very excited to have him here today. Ezra Cohen MD is a professor of medicine at UC San Diego Health and chief of the Division of Hematology-Oncology, co-director of the San Diego Center for Precision Immunotherapy, co-director of the Solid Tumor Therapeutics Program, and associate director at Morse Cancer Center overseeing Translational Science. A physician scientist, Dr. Cohen also leads a laboratory that studies novel cancer treatments, including immunotherapy, and has made major contributions in understanding how targeted cancer therapies work. He recently served as editor-in-chief of Oral Oncology, has authored more than 170 papers, and currently serves as senior editor for clinical cancer research. He has been the principal investigator on multiple studies of novel agents in head and neck cancer and other solid tumors in all phases of development. Dr. Cohen completed residencies in family medicine at the University of Toronto and in internal medicine at Albert Einstein College of Medicine, and completed a Hematology-Oncology fellowship at the University of Chicago. Prior to his arrival in San Diego, Dr. Cohen was co-director of the Head and Neck Cancer Program, Associate Director for Education and Program Director for the Hematology and Oncology Fellowship at the University of Chicago Comprehensive Cancer Center. Please help me welcome Dr. Ezra Cohen.
Thank you so much, and thanks for the invitation to speak, and it's really a pleasure. I used to live only about 5 minutes away from the community center, so that picture reminds me of my former neighborhood. And what I'll be talking about today, as the title suggests, is indeed precision medicines, precision oncology, but with a focus on some of the research that we've been doing as it relates to immunotherapy. I'll share my screen now, and I hope everybody can see that. And I hope everybody can hear me well. If we run into any audio or video problems, please just interrupt and let me know. And I'll leave time for plenty of time for questions at the end. And what I've titled the talk is Listen and Observe, because really one of the concepts I'll try to get across over the next 40 to 45 minutes is that the information that we need to treat patients' cancer is usually there in front of us. It's just a matter now of changing our paradigms to listen to the right notes that the cancer or the person's immune system is telling us, and observing what we see in the clinic to turn it into new treatments in the laboratory. So this will focus on immunotherapy, but a lot of the same principles apply to targeted therapy and other ways of treating cancer. But let's go back in time a little bit. And of course, we know that the current approaches to cancer are somewhat non-specific. We have traditionally or historically used surgery to try and remove a cancer. And of course, that's been done for centuries. And with obviously quite a bit of success, especially if the tumors are small and can be easily removed. Then, about a century ago, radiation therapy was discovered and implemented. And that really involves delivering a high energy to a specific part of the body. The technology to deliver radiotherapy has improved markedly, mostly in the form of sparing normal tissue and focusing that energy more and more on the tumor. And of course, radiation oncologists are happy to say that theirs was truly the first targeted therapy, targeted using a technology rather than a biology, if you will. And then, of course, there's chemotherapy. And many of you probably know that essentially chemotherapy is a DNA toxin. It's a poison to the DNA. And because cancer cells replicate at a much higher rate than most normal cells in our body, we take advantage of that higher replicative ability of cancer and poison the cancer DNA. Therefore, when those cells go to divide, as all replicating cells do, they're unable to do so and die. And that's essentially the principle by which chemotherapy works. The problem, of course, is that all of these have limited applicability and limited ability to cure patients, especially as the cancer is advanced. And so we ask ourselves, can the immune system help to control cancer? And I do believe the answer is yes. And I'll show you not only an example, but some of the research that we've been doing that I think will help solidify my answer to that question. But let's talk about the immune system for just a little bit and recognize that the immune system really exists to protect us from infection, not necessarily from cancer. Now, the immune system can be active against a person's cancer, but let's keep in mind that that's not really the reason we have an immune system. The reason we have an immune system is to protect us from complex pathogens in our environment, primarily viruses and bacteria. And in fact, our immune system is highly developed evolutionarily and has two main components, an innate and an adaptive immunity. The innate arm is the one that is always on. It is incidentally evolutionarily conserved. We see the innate immune system as far down as insects. And what this does is it responds first, and it responds quickly within hours. It recognizes features that are common to all viruses and bacteria. So essentially recognizing short strands of nucleotides or peptides, and it is highly inflammatory. So the innate immune system is that first defense that responds very quickly. The other part of the immune system we've called the adaptive arm, and this requires induction. It requires the immune system essentially to recognize, prime, and learn. And I'll show you what I mean by that in just a few minutes. But it takes days to weeks. It recognizes unique features of specific viruses and bacteria. And so inherently, the adaptive arm of the immune system goes after very specific targets rather than broad. It begins to funnel it down to just those cells, for instance, that are infected. And it has a memory component to it. And in fact, it's that memory component that allows vaccines to work, such as the tetanus or mumps or the rubella vaccine that many of us have received as children, and usually don't have to, in some cases, never have to receive again, or have to receive periodically years later. It's that memory component that allows that. And then, of course, it makes the kill very specifically to the cells of interest. Here's the reason, though, to get excited about immunotherapy when it comes to cancer. This is what we call a Kaplan Meier curve. And for those of you who aren't, Kaplan Meier survival curve. And for those of you who aren't used to seeing it, let me just explain what you're looking at. On the x-axis is time, in this case measured in years. And on the y-axis is the percent of people in this cohort, in this group, in this population that are alive. So we start at 100% at the top of the y-axis. And as patients unfortunately die, that curve gets lower and lower, and eventually, reaches its nadir. Now, this is a curve that represents the survival of patients with advanced cancers. Of course, it's a generalization, but the point being made is that for patients who have advanced or metastatic disease, the curve will go to zero. There are very few patients who survive metastatic cancer in its natural state. Now, we've developed therapies, as I talked to you about in the first slide, surgery, radiation, chemotherapy, that have been able to, what we, in our parlance, say it shifts the curve so that the average patient does live longer. However, the curve still goes to zero. So it takes longer to progress, and that's a meaningful advantage, but we're still not curing people with our current approaches. Now, immunotherapy is different because what we're seeing with immunotherapy is what we've called a tail on the curve. And what I mean by that is that, in fact, the curve that for the average patient, we don't see a dramatic difference yet, with some exceptions. But what we do see is patients who are long-term survivors, and that curve is not going to zero. In the case of most solid tumors, we actually see about 15% of patients who are alive 3, 4, 5 years later that we really would have expected not to be alive at that time with metastatic disease. And many of those patients have had complete remissions. But you can also see from this curve that there's a lot of room for improvement. And that's what I'll try to talk to you about. And what we think is a precision approach is one of the ways to accomplish that, and probably one of the major ways to do that. So we've made progress with immunotherapy, but there is room for improvement. Well, let me give you an example to really put this into real life terms. This is a gentleman who presented in 2015 with a HPV, human papilloma virus positive base of tongue squamous cell carcinoma. You can see that the tumor was fairly advanced at presentation. For those of you who aren't used to looking at PET scans, what we don't like to see red or orange or yellow. Those are active areas, and in this case, those areas represent this patient's cancer. And from the PET scan, we could see that the patient had a cancer in his tongue, and the red area or orange area to the side represents lymph nodes. So not only did he have the tongue cancer, but it had spread to lymph nodes. He was treated completely appropriately with a drug called cetuximab in combination with radiation, and he did fine on the treatment. He completed it without any interruptions or dose reductions, and was getting ready to have another PET scan about 12 weeks after completion of radiation. And what we expect to see on that PET scan after radiation is a complete disappearance of the disease. He was being treated with curative intent. We wanted to cure, or his doctors, he was being treated at the University of Southern California, his doctors were attempting to cure his disease. Well, this is the PET scan 12 weeks after finishing radiation. And what you can clearly see is that he had dramatic disease at this point. And not only was there evidence of cancer, but it was actually bigger than when it started. This was clearly an aggressive cancer that unfortunately did not respond to our best curative intent therapy. This was confirmed by biopsy as a true failure of treatment. He had recurrent disease. At this point, the standard of care for a patient like this is surgery. That surgery would have involved what we call a total glossectomy and pharyngectomy. In other words, the surgeon was proposing to remove his entire tongue and his throat. That would have made it impossible for him to eat normally, and he would have had to learn how to speak completely differently. He did not want to do that. He felt that that would be too much of an impairment on his quality of life. And he asked his treating physician at the time whether there were any other options. And his treating physician and I know each other quite well, and we're colleagues. And we had some interesting clinical trials going on at the time using immunotherapy. This is one of them. And so I said, well, listen, why don't we have him come down and we'll do a consult and we'll talk to him about the options and see if he's interested. And so we did have this clinical trial that involved a PD-1 antibody, PD-1 being the target. That drug was and still is called pembrolizumab, and an inhibitor of an enzyme called IDO, and that drug was called paclitaxel. So here was a study that combined two immunotherapy drugs in an attempt to treat patients who had difficult to cure or incurable head and neck cancer. Well, he started the study, and about 2 or 3 weeks after he started, he gave me a call and he said, Dr. Cohen, I think something's wrong. My pain has increased, and now I'm having a lot of difficulty swallowing. I said, Ricky, hold on a second. This is too fast for your cancer to have progressed. And I wonder if the immunotherapy is doing exactly what we want it to do. I'm going to give you some more pain medicine. Go ahead and do a liquid diet. You can get enough nutrition as long as you can swallow liquids. And let's see how things go. And I'd like to keep you on this treatment. I don't want to give up. And in fact, this was his PET scan on May 10th. And I think what you can appreciate is that the lymph nodes are gone. So those lesions that were on the sides of the neck are now completely disappeared. And the tumor in the tongue is almost completely gone. And in fact, a few weeks before this PET scan, the patient called me and said, I haven't used pain medicine in 4 days. I'm swallowing better than I have in a year. And in fact, jokingly, he said, I think I just coughed up my tumor. And indeed, I think he probably did cough up part of his tumor because, as you can see from the PET scan, it's almost gone. That was on May 10th. On July 12th, so about 8 weeks after that, his tumor was completely gone. And I'll draw your attention to the fact that the year was 2016. The gentleman in question was, and still is, Ricky Rocket. Some of you may remember a band named Poison. And this was an article that ran in People magazine that really documented the story at the time of Ricky getting on this treatment, having a complete response, and doing really incredibly well. This article was from 2016, but now it is 2021, And Ricky is still free of disease and doing extraordinarily well, living pretty well a normal life, including going out on tour with Poison. This was their last tour in 2018. They actually had planned to do one in 2020, but as many of you know, concerts were all canceled in last year because of the pandemic, but hopefully they'll be able to do it again. But the point being made is that when immunotherapy works, it can work dramatically well. And the question, of course, or one of the questions, of course, is to ask, well, why did it work so well for Ricky Rocket? What was going on with his tumor and with his immune system that allowed this treatment to unleash that power of the immune system and completely eliminate his cancer for what looks like, and I'm hoping, forever. It's been now almost 6 years. And so to really get at that question, we have to step back and we have to think about, well, how does the immune system actually respond to cancer? And this is broken down in this figure very nicely in 7 steps. The first thing that has to happen is that the cancer has to release antigens. Antigens is what the immune system responds to. Once those are released, the next step is that a specialized cell of the immune system called an antigen presenting cell or dendritic cell has to pick up these antigens and essentially present them to the immune system, saying, hey, there's something going on here and we need to respond to it. The next step is what we call priming and activation. And this is part of what I was talking about before, the adaptive immune response, where the antigen presenting cells and T cells, which are a very important effector cell of the immune system, start to talk to each other mostly in the lymph nodes, and say, the antigen presenting cell essentially says to the T cell, hey, I don't like this. There's something bad going on in this body, in this system, and I'm going to give you the instructions to go out and find the cells that are abnormal and kill them. So the T cell gets that message. The T cells then go and traffic to tumors. They infiltrate the tumor microenvironment. So they go from the blood vessel right into the tumor. They recognize the cancer cell based on the message that they were given back in step 3, and they kill that cancer cell. Now, killing the cancer cell leads to further release of antigens, and the whole cycle starts again. And the point, as it applies to Ricky, is that we think that this is exactly what happened. Now, what we've learned along the way, the idea, of course, of immunotherapy is not new. It's been around for over 100 years. But what we've learned along the way is the specific elements that we can begin to target and use as therapies. Some of those elements are stimulatory factors, that is, they stimulate an immune response, and they're shown here. And some of those elements are inhibitory factors. So these are naturally and physiologically occurring inhibitors of the immune system. And if you think about it, they have to be there, because for the immune system to really work well, we have to be able to turn it on. Now, again, remember, eliminate the virus or the bacteria that the immune system was designed to do, and then turn it off. We don't want our immune systems on all the time. And so we have to have these inhibitors of the immune response in order to downregulate the immune system. Well, both these stimulatory factors and inhibitory factors can be used in cancer therapy. And in fact, some of those are already being used and approved, such as antibodies to CTLA-4 and antibodies to PD-L1 or PD-1. And in fact, that's what Ricky had, was an antibody to this receptor called PD-1. Well, immunotherapy in the last several years has been incredibly successful. And here you see a list, and in fact, this needs to be updated on a regular basis, of cancers where immunotherapy has been approved over the last probably 6 to 8 years. And that list continues to grow. The importance of this figure is not to read every word of it, but to give you that sense of immunotherapy really has had widespread application to cancers with a lot of success so far. But remember that curve I showed you. There's room for improvement. And that, we think, is going to come from a personalized or precision approach. So let me tell you about what we've been doing for the last 15 or 20 minutes of the talk. We hypothesized that if we were going to create a truly individualized therapy, we had to identify the mutations in each patient's tumor that was recognized by their T cells. And we called these neoantigens. So remember that cancer is a disease of mutations. It's a disease of alterations in our DNA that give cancer cells a growth advantage. We hypothesized that those alterations, those mutations, should be recognized by the immune system as being different, because the immune system would never have seen those. They're inherently new to the immune system, and that they should be recognized by the T cells, and that those T cells would be present in the cancer patient's body. The other thing we wanted to do was turn that, if number one was true, turn that into a therapy. And we thought that the most readily available way to go to the clinic was to create a vaccine, because vaccines were being used, they were readily available, the technology was there, and we could direct that vaccine against these so-called neoantigens that represent the mutations in the person's cancer. And so about 5 years ago, we embarked on an approach to try and do that. And what we do is we take the tumor from the patient, we sequence the DNA and the RNA through next generation sequencing. We identify the mutations, and then using an algorithm and bioinformatics that we developed, we identify what we think are going to be the most immunogenic mutations. In other words, the mutations that individual's immune system should be most responsive to. And I can explain what's involved in that bioinformatics if you're interested, but suffice it to say that we create a list of mutations in that individual's cancer that we think would be the best candidates for therapy, because we think that their immune system would be most likely to recognize them. We create a peptide set based on that information, and then we take about 50 cc's, that's about 8 tubes of blood, from the patient. We extract the patient's T cells from that blood, and we basically put those together, and we ask a very simple question. Which of the peptides, which of the mutations is that patient's immune system recognizing? And with that, we get the neoantigens, the verified neoantigens that tell us what that patient's immune system is responding to in his or her cancer. In fact, it turns out that this methodology has about a 10 times higher success rate than any previously described method, and continues to be quite successful. We've done this in every cancer that we've looked at, and so this was one of the first discoveries that we made, is that in fact, irrespective of the individual, irrespective of the cancer, we see these T cells responding to neoantigens across the board. even in cancers that have low mutational burdens, even in cancers where we don't typically think of them as immune responsive. We see these T cells that recognize a patient's cancer mutations or their neoantigens. And so now we were ready to turn this into a clinical trial. And we had to find a vaccine or a vaccine platform that could do this. And what we decided to do was use a peptide vaccine with what we call an adjuvant. And in fact, we treated our first patient in October of 2018, so now a couple of years ago. That patient, as you can see in the middle, is Tamara. Her name's Tamara Strauss. I'm there actually giving her the first injection of the vaccine. That, by the way, that was the first injection I'd given in about 2 decades, but I think I did it correctly. Behind Tamara is her mother, Iris. Next to Iris is one of my colleagues, Aaron Miller. And kneeling next to Tamara is another colleague, Steven Schoenberger, and it's really been the three of us working closely together, in addition to Bjorn Peters and his team, that have gotten us to this point. And here's the schema of the study. What we do is, as I described to you, we take the patient's tumor and blood through our workflow. We identify and select the neoantigens. We prepare the vaccine. That whole process takes about 12 weeks. And then we're ready to treat the patient over about a 15-week period with the vaccine and the PD-1 antibody. Now, what we saw in terms of results really, actually, I have to say, surprised me, delighted me, but I have to admit, I didn't expect to see what we saw. The first thing we recognized was, and this is Tamara's tumor, was that what we were achieving was elimination of mutations that we were vaccinating against. Let me tell you what I mean by that, because this is not, let me tell you what this graph shows. Tamara's vaccine had we immunized her against 2 of her mutations. At the bottom on the, you see EP300 and HLA-DQA2. These were 2 mutations present in her cancer. They showed up as neoantigens. We identified them, and we put those 2 in her vaccine. The MEN1, we recognized, identified as a neoantigen, but the sequence of the peptide could not be put in her vaccine. It didn't pass quality testing. And so she had 3 neoantigens that we identified. 2 of them, EP300, HLA-DQA2, were in the vaccine. The other one, MEN1, was not in the vaccine. The blue bars in this graph represent the level of those mutations in her cancer before the vaccine. The red bars represent the level of the mutations in her cancer after the vaccine. And what you can see is that the MEN1 that was not in her vaccine didn't really change from before to after. But the 2 mutations that we vaccinated against essentially disappeared from her cancer. And what this told us was that we were on the right track. Moreover, we saw this in every patient that we treated in this cohort. Here's another patient. This is patient number 5. And what you can see is that 4 of the 5 neoantigens in the vaccine completely disappeared in this patient's cancer. Interestingly, one of them, this is the ZNF57 that you see to the far left, didn't disappear at all. It was in the vaccine, but the vaccine wasn't able to eliminate it. And we have yet to understand why 4 went away and the other didn't. But the point is that at least 4 did go away. Not only that, what this illustrates is that, and this is patient number 5 again, that we were able to see the specific T cells increasing in number that we were vaccinated against. So this was not a global increase in all the T cells in this person's body. This was actually a very specific increase in the T cells that we were most interested in activating. And what this told us is that we were on the right track. But what really, really got us excited was patient number 4. This is a patient with head and neck cancer who in March, before he started the vaccine treatment, could not work, could not play with his children. He was 42 years old. And the cancer really was very advanced. He had failed 4 prior lines of therapy. And you can see that he has a cancer now outlined in red right next to his vertebral column in the chest. And he started the vaccine in late March of 2019. On the first CT scan in June of 2019, his tumor is almost completely gone. And in June, he is back at work. He is playing with his kids. He's living essentially a normal life. Here's another CT scan, a different cut. And you can see that in March, he had these 3 small tumors on his chest wall. And in June, they are pretty well completely gone. And he had about a 90% response to this treatment. And with all of that, the clinical, the immunologic, the sequencing data, we really felt that we were on the right track, but we felt that we could do better. Because at the time, our preclinical work, so the work in the laboratory, was telling us that if we made a few changes, we might be able to get even better results in our patients. And so we did that in what we called Arm C, so another iteration of the strategy. But this time, we added a stronger adjuvant, so something to help stimulate the immune system. We increased the number of neoantigens that we could target in the vaccine. In the prior iteration, we limited ourselves to only 5, but this time we went up to 24. And we increased the number of vaccine doses, because in our preclinical models, in the mouse models, what we were seeing was that if we took a priming and then a boost approach. So in other words, we did 3 vaccines really rapidly, back to back, and then extended the vaccines in a boost over about a 6-month period, we were getting better results. And so that's exactly what we did in people. And here's the schema of that. Still in combination with this drug called pembrolizumab, the anti-PD-1 antibody. And the first patient we treated on Arm C was this patient with tumors in her liver. And what you can see from October of 2019 to January of 2020 is a reduction in that largest tumor, going from about 5 centimeters to 4.4 centimeters. Here's another cut, another tumor in her liver, going from 3.5 centimeters to 2.8 centimeters. Her cancer didn't completely go away, but the fact that it was getting smaller, and this is a person who had had pembrolizumab before, the fact that it was getting smaller, again, I think reiterated to us that we were on the right track. And so we've now, with this strategy and many others, we formed what we call our Precision Immunotherapy Clinic, with the idea that we really felt strongly that the next steps in cancer therapy, and especially immunotherapy, was understanding what the patient's tumor was telling us. So listening to the patient's cancer, understanding what their immune system could respond to and was responding to. So observing those elements in the immune system that could be increased, that could be augmented, and putting that information together to really individualize therapy, either through existing treatments or bespoke therapies, as I just showed you, in the vaccine or even cellular therapy. And that's what we're trying to do in the Precision Immunotherapy Clinic, where we see patients with all kinds of cancers in an attempt to really individualize that treatment. And so I've left time for some questions. Let me leave you with a few thoughts. That the era of cancer immunotherapy is definitely here. We're really now at a point where we are seeing results that we would never have expected even a short time ago. And I do believe that this is just the beginning. That certain class of agents, specifically the anti-PD-1 or anti-PD-L1, have an established role in multiple cancers. I showed you that, that graphic. And that checkpoint blockade and other immune modulators are being tested now in every cancer. And that immunotherapy can potentially cure patients even if they have metastatic disease. I showed you that example of the one patient, Ricky Rocket, but he's not an isolated case. And we are seeing now these prolonged complete remissions in about 15% of patients that we treat with immunotherapy, which is, without a doubt, better than where we were before, but we do have a lot of progress to still make. And we have a lot of questions to answer. How do we make personalized immunotherapy more effective? What biomarkers better define benefit? How can we better select patients? How do we treat patients who are refractory? So still, the majority of patients don't respond to immunotherapy, and we have to understand why and what we can do for those patients. And how to make these approaches more available. We need to shorten the timelines. We need to improve distribution. And of course, we need to lower the costs. All of these things will happen as the technology improves and becomes more available. But not only do we have to make the science better, but the wonderful science that can't be implemented doesn't do people much good, and we have to work on that as well. So once again, I'll thank you for the opportunity to speak today. Thank you for attending and your attention, and I'll be happy to take questions.
Thank you, Dr. Cohen. We do have several questions in the chat, so I'll start with from Sharon. She says, currently, is this only done at the late stages of cancer? Well,
no, it's not. In fact, the paradigm in cancer is to start in the late stages with experimental therapies. And if you think about it, ethically, that makes sense. Patients who don't have a lot of options are the ones that are usually candidates for clinical trials, but not exclusively. There's a lot of clinical trials in early stage disease, but immunotherapy did start with patients who had very few other options. Having said that, we've now moved it in, including the vaccine, we've moved it into patients with earlier disease. And in fact, the trial that we're doing now with the vaccine takes patients who have no evidence of disease. So let's say a breast cancer patient who got therapy, her CT scans don't show any cancer, but we know that she has a significant chance of the cancer coming back. Well, we're now enrolling patients like that in our current arm of the study, giving them the vaccine with the idea that we can prevent or reduce the risk of the cancer coming back. So we are beginning to take all of these strategies into earlier and earlier stages. And if you use your imagination, as maybe the question is alluding to, we can even begin to think about immunotherapy as a preventative strategy, so patients never get cancer in the first place. And there's work going on in that regard as well.
Thank you. Dr. Cohen, how can patients learn more about seeing if they qualify for the study?
Yeah. So if you, can I go back to a slide? Let me share again. Let me go back a couple. So there is a number at the bottom of this slide and a website. And I can give you that number if people can't write it down, but that would be not only for the vaccine study, but for any of our trials, and that's the way to get in touch with our personnel.
Great, thank you. A question from Juliet. What are your thoughts on using personalized vaccines for patients who are stage 4 without evidence of disease?
Yeah, so that's exactly the type of patient or one of the types of patients that we're currently enrolling. In fact, we just enrolled a gentleman who was diagnosed with bladder cancer. He did very well with standard therapy, and he has no evidence of disease. He had a cancer come back, or a lesion come back that was resected. But we know, even though the CAT scans and the PET scan don't show any cancer that we can see, we have a pretty good sense that he's at high risk for recurrence, and he's about to start the vaccine study. So he had stage 4 disease, still has, in theory, stage 4 disease, but we can't see it on scans. And we think that that's when immunotherapy is going to be most effective with microscopic disease, high risk of recurrence, and that we think that the immune system is going to be most effective when the cancer burden is actually low. So we're optimistic about that.
Thank you. Question from Canary. Have you had any success with sarcomas? Also, does absence of MSI and gene testing mean that a patient will not benefit from immunotherapy?
Yeah, so let's deal with the two questions separately. The sarcoma, we have identified neoantigens in sarcomas. We have not treated a sarcoma patient yet. It's funny you should say that, because the patient we are now taking through the vaccine methodology is a young woman with a rare type of sarcoma, who is currently free of disease after having a complete response on chemotherapy. She's 18 years old, being treated right now in New York. And she's enrolled in the trial, and so she'll be actually our first sarcoma patient. But yes, this should work for sarcoma. It really applies to every cancer as far as we can tell, and sarcoma included. Sarcoma is interesting because I don't know if the questioner is aware, but sarcoma is usually marked by fusions. So it's a different type of alteration in the DNA than mutations. And it'll be interesting to see if the fusions respond differently. So academically, it's an area of interest for us, sarcomas and other fusion driven cancers versus let's say lung cancer, breast cancer, head and neck. The MSI issue is interesting. So MSI stands for microsatellite instability, and it was discovered by a group at Hopkins, the Johns Hopkins. This is probably about 5 years ago. That tumors that had this characteristic that we call microsatellite instability respond very well to available immunotherapies. And it turns out that actually the reason that they respond is part of the discoveries that we made, that these tumors harbor neoantigens that are very immunogenic to the immune system. That is, they produce a very strong immune response. And if we can unleash that immune response, those patients can do, about half of them, about 50%, end up doing incredibly well with immunotherapy. Those patients end up also having a very high tumor mutational burden. They have a lot of mutations in their tumors. But the nice thing about the approach that I showed you is that it doesn't depend on microsatellite instability. It doesn't depend on the number of mutations in a patient's tumor. All it really depends on is the immune system's ability to recognize things that are different. And as I mentioned, we've seen this in every patient that we've tested, that the immune system is incredibly good at seeing those things, and has the repertoire to be able to destroy the cancer. The question, of course, from that is, well, why has the immune system not done that already? What's it waiting for? And we think the reason that is that the cancer actually grows slowly over years in a person's body, and that over that period of time, the cancer actually sends messages to the immune system, basically to say, don't destroy me, don't get rid of me, I'm not dangerous to you. What we have to do with immunotherapy is change that message and say, no, 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 the cancer has been fooling you this whole time. It's really, really dangerous, and you need to destroy it. And we're going to give you a different set of instructions to do that.
Thank you. Another question, are the clinical trials only for UCSD health members? And if open to all, this person has scripts, would they need approval?
Most of the clinical trials are being conducted exclusively at UCSD. So the short answer to the first question is yes. For most of the efforts, you'd have to come to UCSD to get the treatment. Having said that, we do have collaborations with Sharp. We do have collaborations with other institutions outside of the San Diego area. We have collaborations with Eisenhower Medical Center in Palm Desert. We haven't yet established collaborations with Scripps. We're trying, so talking to them. But for the most part, yes, the therapies would have to be conducted at UCSD. But that's not a problem. We see a lot of patients from Scripps. We're in constant contact with the medical oncologists there. Very, very good colleagues, and so easiest way to do it is just to get in touch with us, and we can take care of the rest.
Thank you, Dr. Cohen. I'm being asked for the phone number again. Would you be able to repeat that phone number, and I could type it in the chat?
Yeah, sorry. Not a problem. There you go. Can you see it at the bottom?
Yes. Deb, will you go ahead and type that? Yes. Okay, we'll go ahead and add that to the chat. So there's another question, Dr. Cohen. That's okay. Are there any trials on metastatic prostate cancer?
Oh yeah, lots of trials. You can imagine that prostate cancer is a major cancer type, unfortunately. But we have a major effort in prostate cancer. In fact, we're collaborating with scientists at that came from the Scripps Institute. That's not the Scripps Health System. It's a separate research institute. They developed a type of cellular therapy that specifically targets prostate cancer, that targets an antigen that's only expressed in prostate cancer cells called PSMA. You may have heard of it. And what this does is it recruits the T cells right to the cancer. And we've already started that clinical trial. We're already treating patients. In the laboratory, it worked incredibly well. And the same type of strategies have actually been approved in lymphomas. And so we're very optimistic that this is going to work in prostate cancer. That's just one example, though. There are many efforts going on in prostate cancer, including early stage prostate cancer, to try and treat patients earlier on.
Thank you. Do tumors change? Can Keytruda work years later on new tumors?
Yeah, so yes, unfortunately, tumors change. And in that sense, I always thought that they don't play fair because they mutate and they change. And a tumor that responds initially over time may not respond. And in fact, I didn't talk a lot about targeted therapies. We have a major effort in targeted therapies, so non-immune therapies that target specific mutations in the tumor. And the limitation there is exactly as the questioner asked. Unfortunately, the tumor changes over time and stops responding to that targeted therapy because the mutation disappears or the tumor develops another mutation. And so we have to think about ways to be proactive about that. The question asked specifically about pembrolizumab, and by the same token, what we found is that pembrolizumab activates specific T cells that can destroy the cancer. But then what happens in some cancers is that that antigen that the T cells were activated against, it's a neoantigen, the cancer stops expressing it. And all of a sudden, the pembrolizumab stops working. So there are proactive ways to address that. And we're now working on that. And we think the best way to do it is actually to hit the cancer hard initially so that it doesn't have the opportunity to develop that resistance. In other words, sterilize it early and cure the patient so that years down the road, the cancer doesn't have an opportunity to mutate or to become resistant.
Thank you. There's a question from Anonymous. If someone has no evidence of disease and thus no current tumor, what do you use to make the personalized vaccine?
We use their old tumor. We use archival tissue. Most patients have had, a biopsy or a resection. So we use that. We use their blood now. So we have their T cells in present time. And we ask, what are their T cells responding to? Granted from an older specimen, but we have to use something. So.
Thank you. Another question regarding trials. What about trials on bladder cancer? I don't think I saw that on the list.
Yeah, so bladder is definitely on the list. We have a very active program as well in bladder cancer. Tyler Stewart is the main person for bladder cancer. And bladder cancer, interestingly, is a cancer that's been responding well to immunotherapy. Again, lots of room for improvement, but we have a very active program in bladder. Tyler Stewart would be the person, but again, it's the same phone number.
Great, Dr. Cohen. And regarding that phone number, we did not get that. It's 858. Will you go back to the slide one more time and we'll say it out loud and type it out?
I will. How about this? I will just leave it up.
It was
Sorry
it was
about
too
that.
fast. There you go. So it's 858-246-5300. And thank you so much, Dr. Cohen, for being here today, part of our Distinguished Speaker Series. Thank you all for those who attended. This is very valuable information, and hopefully those who need it will reach out and we'll be able to get some resources available. So thank you so much, Dr. Cohen. Again, everyone who attended, thank you very much. Have a great day and hope to see you back soon.
Thanks very much. Thanks for the invitation.
Take care.
Bye-bye.